hypertension to treat or not?
So a warm good morning to all. At the outset, I would like to thank Ksos for giving me this opportunity. So today I'll be clearing out all your doubts regarding ocular hypertension. So how many of you treat here ocular hypertension? Can hands up if you see a patient with IOP high? Yeah, yes. As Madam told, we should see what all things and then treat. Okay, so we'll go through it. So I'll be dealing about the definition, what is our queries, the OHTS landmark study, the risk stratification and the management options, and we'll summarize the management at the last. So ocular hypertension is defined as an intraocular pressure of more than 21 millimeter mercury in either of the eyes, at least at 2 occasions measured by the Goldman's lapillination tonometry, with open angles and no evidence of any structural or functional damage and no systemic or ocular cause of raised intraocular pressure. So 4 to 10% of the adults over 40 years are having IOP more than 21, and they are classified as ocular hypertensives. And actually it is more prevalent than primary open angle glaucoma, and the incidence by the value rise study was at 3%. So it is the blue portion, what you're seeing there is the ocular hypertension, proportion of the ocular hypertension compared to the POAG. So what is our queries is that whether should we treat all patients with high IOP without any optic nerve damage, or how often should we follow up, and will the treatment prevent the incidence of glaucoma? So ocular hypertension treatment study was the landmark study in this field, and it was the study conducted to debate the management of the ocular hypertension. And it was conducted in 3 phases, and the phase 1 was conducted between 1994 to June 2002. And the main question was whether this treatment will prevent the incidence of primary open angle glaucoma in ocular hypertensives. And again to define whether there is any baseline clinical and demographic features which will predict the incidence or the risk of POAG in ocular hypertension. So about 1,636 patients were studied, and they divided into 2 groups. And one was the observation group and the other one was the treatment group. And the aim was to decrease the IOP 20% from the baseline, or either to bring the IOP less than 24 millimeter mercury. So one was kept for observation and the other one was treated. And the results for the 5-year results was that the mean IOP was there was a 4% decrease in the observation group, but in the treatment group there was a 22.5% decrease in IOP in the treatment group. And again the probability of developing glaucoma was 9.5% in the observation group, and it was about half or 50% decrease of incidence in glaucoma in the treatment group. So the study concluded that the ocular hypertensives will prevent or decrease the incidence of POAG in ocular hypertension. And the other thing was that the other aim was to find out the baseline or demographic or clinical factors which may help or predict the incidence of open angle glaucoma in ocular hypertensives. And the risk factors they found was one is the older age, then the thinner central corneal thickness. So for every 40 micron decrease in the central corneal thickness, they showed an 81% risk of this primary open angle glaucoma. Again, the higher IOP, larger cup disc ratio, again not by the color, and as told, it's by the contour of the blood vessels. And the greater pattern standard deviation, which is usually seen at the right end of the visual field report, we'll see that a pattern standard deviation was taken into account. And with each 0.2 decibel increase in the pattern standard deviation, there was a 22% increased risk of POAG in those ocular hypertensives. So these were the risk factors, and among those factors, central corneal thickness was the most important factor, which showed a 71% relative risk increase in the relative risk for POAG. And this is a pattern standard deviation which is usually seen at the right side of the visual field, which is taken into account in this study. So what is the problem of this OHTS one was that they told that it is not cost effective to treat all the patients with ocular hypertension because of the increased prevalence, the side effects, cost, treatment, and all. So they rather advised, as we saw, a risk stratification to see what all patients have what all factors we saw, which predict the incidence of POAG, and then how to follow up these patients. So this OHTS2 study was done actually to see whether if we delay the treatment, whether it will lead to any irreversible glaucomatous damage. So which group was kept for observation? They started treatment in the observation group, and they named it as the delayed medication group, and the delay was about for 7.5 years. And the other one continued as the early medication group. So it was the delayed medication group and the early medication group. And they could see that there was no any significant difference in the incidence of POG between the two groups, and hence they made a conclusion that delaying treatment in most of the participants does not lead to any irreversible damage during the 7.5 years delay. And they also told that the benefit is more in the high-risk individuals, and there is only little benefit in the low risk. So that was their conclusion after the OH2S study. So whether we should treat only the high risk and no need of treating the low risk patients. So depending upon the risk factors which the study brought, actually a risk calculator was formed. And it is actually a calculator which estimates the 5-year risk of the incidence of POAG in ocular hypertension. And just if you can go the online, you can just see if you click it, the thing will open and you can just enter the values and it will give you the risk. And the methods of measurement was, they had particular measurements, they just entered, okay. The IOP is actually an average of the 3 measurements using Goldman's appellation tonometry. CCT again, at least 3 measurements using ultrasonic pachymetry. The vertical cup disc ratio is by, as I told you, by the contour method. And the pattern standard deviation. So that the baseline, a proper evaluation should be done to the patient. The IOP should be measured, the CCT should be measured. Again, the proper fundus examination should be done, and the visual field should be done for entering these proper values into those calculators. And this again the STAR calculator, which included the same risk factors. So this is our point system. So there was a point system was introduced. So depending upon the age, you can see depending upon the age, the IOP, the CCT, again the cup disc ratio and the pattern standard deviation, and the risk is given at the end. And they classified it as, if the risk is less than 6%, they were considered as a low risk, 6 to 13% under the moderate risk, and more than 13% under the high risk for POG incidence. So we have a patient here, a 54-year-old patient with an IOP of 24 in the right eye and 26 in the left eye with open angles. His CCT again the normal range, and the pattern standard deviation was less than 2 with a vertical cup disc ratio of 0.3 and 0.4 respectively. So if you are entering into this risk calculator, you can just enter the age, and then the intraocular pressure is being entered. It's the average of the 2 eyes. Again the CCT measurement, at least 3 measurements by the ultrasonic method. Again the average of 2 eyes, and again the cup disc ratio has been entered, and the pattern standard deviation, and the risk is given at the below. You can see this is a 10% risk. So it again comes to the moderate group. Another patient, a 65-year-old patient, again here the IOP is almost in the same range, but the central corneal thickness is lesser. It is only 510 in the right eye and 513 in the left eye. The other parameters are almost equal. So if you are entering into this calculator, you can see that the risk is more for the thinner central corneal thickness. It comes into the, it's between the lesser than 530. The risk is 20%, which comes to the high risk group. So this risk calculators are again having limitations of its own, because it is actually for the patients who were studied, similar to the participants who studied in the OHTS and the EGPS study. And actually again it should help us our clinical management, not just to find the risk and treat. You should, again it aids with our clinical management. Also, you should exclude the other causes of secondary raise in IOP, like steroid-induced glaucoma or any history of trauma, the syndrome, Bosnian-Schlossman syndrome. Again, the pigment dispersion syndrome, which is usually more common in myopes. And the proper gonioscopy should be done before coming to the diagnosis of an ocular hypertension. So how to monitor? It was, if the low risk patients, yearly monitoring is enough. But if it is moderate risk, at least 6 months. And if it is high risk, at least more than, if it's high risk, you should go for a 3-monthly visual field evaluation. The other possible risk factors also you should consider while by taking the treatment decisions. And the IOP low it by 20%, and the topical beta blockers and the prostaglandin analogs will do. And laser trabeculoplasty has been proposed as an initial management in ocular hypertension. So what will be our take-home message is that first you should find out the risk. If it is high risk, again it needs treatment. Moderate risk, see with the associated risk factors are present or not, and then only treat. And the low risk, just the follow-up is required to see for the early signs of progression or the incidence of glaucoma. So thank you for the kind attention. Another challenge in our glaucoma practice is when we see OCT image, so many reds and so many greens in there. So always we are confused. So I invite Dr. Smita, who is my own teacher, and she's working as a professor in the Government Medical College, Thrissur, and she'll be clearing all our doubts about this red and greens in OCT. Over to you.
Good morning, ladies and gentlemen. Thank you, Dr. Jaini, for this wonderful opportunity. The OCT machine is very easily available in most of the eye hospitals. There is a thrill in using this sophisticated and very rapidly advancing technology, both for the patient and for the ophthalmologist. And most importantly, it is very easy to use. So with all these advantages, there is a real temptation for the doctor to use that color-coded printout to make a diagnosis of glaucoma. And it is here that we should be aware of its limitations. So this was a study done by Stagg and Medeiros, and it was for glaucoma suspects. They found that in a spectral domain OCT of the RNFL, at a sensitivity of 95%, specificity is only 60%. This means that if you want to detect 95% of glaucoma in glaucoma suspects, you end up calling 40% of the normals as glaucomatous. So since we basically use the OCT to find out whether the glaucoma suspect is having glaucoma, that is to make a decision whether the glaucoma suspect is having glaucoma or not. Because this specificity rises very much, it becomes something around 95% if the person actually has glaucoma, mild, moderate or severe. So that is why we should say no to the screening and random diagnosis of glaucoma using the imaging techniques. Now I'm going to speak about the red disease and the green disease. So if you look at this picture, in this thickness, in this RNFL thickness differentiation map, you can see that there is this red area which is large. You can see it on the red-free fundus, red-free and also in the fundus picture. But when you look at the fields, there is a superior field effect. So basically there is no correlation, and this red color is not probably glaucomatous. So the red disease is actually a false positive diagnosis for glaucoma, as the device incorrectly indicates an abnormality in red corresponding to the image when there is no damage. So this incorrect damage, it is like a terrified patient coming with an OCT created damage, which is the red disease. It has greater patient anxiety and cost, unnecessary treatment with its adverse effects, and sometimes may lead to medico-legal issues. So let us look at some of the causes. Most of the OCTs need to function with at least a minimum signal strength. For the spectralis, it is more than 15, and for the cirrus, it is more than 6. I've given the value for others also. So for each unit decrease of signal strength, from the baseline, the average RNFL thickness decreases by 2 microns. So you can see the poor signal strength in this red-free image, where you can see that the branches are not visible in certain areas. You can see the highly granular appearance in the B scan. And so this usually happens when the lens of the OCT machine is not clear, or there is a dry eye on a cortical cataract, and very paradoxically also in pseudophakics. So signal strength has to be established, and it is always written down in the printout. The second important cause is decentration of the measuring ring. You can see that this measuring ring, which should have been centered on the optic disc center, is now decentered superiorly, and therefore the superior part appears thinner as compared to the inferior part, though not in this sectoral map. You have to discard this scan and take another one in which the ring is properly centered. There could be an anterior misidentification of the RNFL. You can see in this area where, so it is important that we look at the screen, and we should be there in the same room as the OCT is performed, so that we can correct the position manually and then measure the RNFL thickness, because otherwise this position, if we take it in this position, it is likely to appear in red. There could be also posterior misidentification of RNFL. You can see these green lines which show the posterior border of RNFL touching the red line at many areas, and that is basically a segmentation failure of the machine. You know that even if there is a long-standing optic neuropathy with, say, no perception of light, there would be some residual glial cells or retinal blood vessels which would give a base thickness of, say, 30 to 40 microns. That would be always measured. There would be nothing which touches the floor, like in this picture. You can see that the patient's OCT is touching the x-axis, and therefore it is giving something in the red here in the sectoral and the Glaucoma maps. So when this was corrected, this gives rise to a normal OCT, normal pattern as is shown in this printout. Another very common, very important thing that can happen is to have a floater on the measuring ring. Now this floater can be patient's own hair or the patient's clothes interfering in between, or it could be a vitreous floater, or it could be the measuring ring straddling across the peripapillary atrophy, or though the myelinated nerve fibers would give rise to a thicker picture, or a PVD. So in the thickness map, you can see the presence of any of these in the form of a non-acquisition of signal in black color. On the other hand, in the deviation map, this comes as a red color straddling the disc, and therefore, since the signal is not acquired, it will lead to a yellow or red disease in your Glaucoma maps, and falsely you can think that the patient is glaucomatous. Most of the times, the hospital where you work won't have the latest OCT machine, or the technician would be new and inexperienced. So the patient may be moving, sometimes the patient may have poor vision and may not see the crosshair of your OCT machine, and therefore the patient would be moving, and then there would be motion artifacts, and such OCTs should not be used. You have to discard them and use and do another OCT. They are best seen by these horizontal lines where the blood vessels, you can see that the continuity of the blood vessels is lost. This horizontal line is more clearly seen. The database with which we compare our patients is usually Caucasian in case of the spectralis, or in the case of cirrus OCTs, there is only about 1% of patients who are Indian. So basically we are comparing our patients with a very, very small database, and therefore the chances of having red disease because of this racial difference is always there. Indian database, I do not know if it is available now, but we must have an Indian database, and many studies, because India is so diverse, many studies show many different kinds of databases. There is no normative database for people less than 18 years of age, or congenital disc abnormalities of very small or large disc, and most importantly, in pathological myopia, you will have a patient who is unable to fix the central crosshair. You will have a patient who has motion artifact because he or she is uncomfortable looking into the machine, or there may be peripapillary atrophy or the floater straddling on the measuring ring, or there may be a normative database absence because the patient has more than -12 diopters of myopia, or there can be a lateral displacement of the RNFL bundle or an anatomical split of the RNFL bundle. So there are so many things which make the diagnosis of glaucoma by the OCT machine very difficult. This was actually a poster by one of my PGs who again reiterated the same factors. Let us now come to the green disease. The green disease is when there is a false negative diagnosis, meaning that the software interprets that there is actually glaucomatous damage when there is no glaucomatous damage. So we feel complacent, we feel that the patient has no glaucomatous damage, that is a false sense of security. This is from a paper by Sunny et al., where in this RNFL, in this red-free map, you can see this RNFL defect, which is seen in the thickness map, which is seen in the deviation map also, but is not seen in the Glaucoma map. In the similar way, there is in another case, there is this RNFL defect. In here, you can see this RNFL defect, which is present in the thickness map, but which is not acquired in the deviation map and neither in the Glaucoma map. So there are chances that the deviation map and the Glaucoma map may not show the defect which you are actually seeing in the patient's eye, and therefore show a green disease. This is a segmentation failure. This is another patient who had a cup with an inferior Drans hemorrhage, and this Drans hemorrhage showed in the deviation map also, besides in the thickness map, but was not seen in the sectoral and the Glaucoma maps. So this is actually a averaging algorithm which doesn't work, and there is this averaging is not a simple averaging algorithm. It's a interpolation of data from the neighboring areas which gives rise falsely to a green color. PVDs can cause traction on the optic disc and pull the disc up, leading to a false security that there is glaucoma when in fact there is no glaucoma. When the PVD collapses, this thing will disappear. And finally, again, I want to reiterate that the OCT is only helpful to make a diagnosis. You should have a complete workup of the OCT just as you do for the visual field, and then you make a diagnosis of glaucoma only by basing on the history, on the optic disc, and the visual field changes. OCT is only a helpful tool. Thank you very much for your kind attention.
Thank you, ma'am, for this wonderful talk. So we'll keep the questions to the end. So I'll be inviting Bindu ma'am, my own mentor, to talk about the topic, which is another big challenging situation where we face after trabeculectomy, post-trabeculectomy hypotomy. So we'll hear from you.
Good morning, everyone. Thank you, Janie, for this opportunity. Now we'll go to the topic itself. A hypotony is defined as an IOP less than 6 millimeters of mercury, and it's not rare. The reported incidence is 1 to 32%, especially when you use mitomycin or 5-FU. Now, when you plan a trab and do a trab, what you want is an ideal bleb, but the same amount of mitomycin in different people for the same time also gives you a many varied type of blebs, which can be an overfiltering or a scarred bleb. That is the very indefinite thing which we cannot plan reaction for all the patients in the same way. So that is the reason why we end up in complication. Not only that, it's also due to the errors or the minimal surgical technique which has to be improvised, can also prevent the shallow AC. Now we'll just come to what are the causes of shallow AC and how do we deal with it. So when to intervene when you have an AC shallow depends upon the cause and also depend upon the extent of the problem. The early, it could be a bleb leak or an overfiltration, and we need not have to intervene surgically in all cases, but we have to intervene only when it is a grade 3, where there is a central both lenticular corneal touch, and the grade 1 or grade 2 when there is a peripheral corneal iris corneal touch. We can do observational treatment, which I'll come to later. Now, why there is a hypotony? It could be an overfiltration or a leaking bleb, or it could be a cyclodialysis cleft, or it could be a choroidal detachment, ciliachoroidal detachment, or egmatogenous RD. Now, the moment you see a flat bleb and a flat AC and do a Seidels. If it is positive, it is a leaking bleb. Now, the main treatment for this is definitely a prevention of it, where when you're doing a trab, you make sure that the sutures are tested for leak and it is a tight sutures. The conjunctiva, meticulously you have to close the conjunctiva and make sure it is a watertight closure. Now, if you have a post-op leak, how do you manage it? Depends upon the size and position of the leak, the appearance of the bleb, the depth of the AC, and definitely whether you have used antimetabolites or not. A small leak along the suture line, usually it's spontaneously or with conservative management, you can deal with it. But even if a small leak with antimetabolite, it may sometimes need a not only conservative management, but like a large leak along the suture line may require a surgical management. Now, what do you mean by conservative management? We can opt for pressure bandage or a large diameter bandage contact lens. Yes, you have to downregulate the steroids and definitely the cycloplegics. And yes, doxycycline has proved to be a better. There is a lot of studies showing that oral doxycycline helps in wound healing in the initial stages. So these are the reactions of the mitomycin. You see the edges of the conjunctiva getting whitening. There's a conjunctival melt here. And this is the whitening caused by the ischemia. All this is due to the antimetabolites. Though you suture it tight, this can happen. And initial stages, this is the large diameter bandage contact lens, which is used to treat the early leak, which is a mild leak. Now, this is the conjunctival melt. Though the conjunctiva is anchored to the limbus, that it just melted away. So, I'm just removing that anchoring suture there, and then you surgically suture the conjunctiva. This is how, this is an NVG case, post-Avastin trab. So then you have to re-anchor it. This was a surgically. And this case, usually during our initial period, we do have a buttonholing in the sclera, especially the sconioschleral junction, where the direction of the crescent might, the learning stage might not be proper. And this was a scleral tear near the limbus, which was the cause for the leaking bleb, and this had to be repaired surgically. So again, you have to do pressure bandage after that, and then reduce the steroids, or you can use a fibrin glue or a surgical repair is the treatment for that. The next scenario is when you have an AC shallow but you have a large bleb. That is because of the overfiltering bleb, and here your Seidels are negative. This is a patient who had an overfiltering bleb, and this is the peripheral CDs which have developed because of the hypotony. It's usually due to a loose scleral flap, and then you treat it only if you have a hypotony is associated with large choroidal effusion. So the management is again observational in the initial stages, reduce the steroids, atropine, and if you want to form the AC, you can form it with viscoelastic or air injection. Again, overfiltering bleb can be treated with a bandage contact lens. You can usually keep a patch over the bleb area, just pressing the bleb area, and then do the patch. This is how, or if you have a Simmons tamponade shell, you can use that. And in the late stage, if it is an overfiltering, you can use an autologous blood injection. And also you can use compression sutures when there is a overfiltering bleb. Sometimes it's associated with large choroidals, especially in cases with older age, post-vitrectomized eyes, nanophthalmos, or high episcleral venous pressure patients. So this is the picture which I was showing, the hypertonic maculopathy. Especially in young myopes, the risk of hypertony is very high. Again, initially it is with conservative with systemic steroids and oral steroids, but then if the choroidal detachment is large and kissing, definitely you'll have to do a choroidal drainage too. This is a late bleb leak, which on opening up had a scleral fistula to melt to, which had to keep a scleral patch graft and then do it. So here the risk is your failure of bleb is very high. This is a 90-year-old male who had previously, many years back, done a trab, and it just came with a spontaneous hypotony, and this was found a leaking bleb. Because he was 90 years, I just did a bandage contact lens, is planning him for surgery, but then with the just bandage contact lens, it healed actually. So in late onset, you can excise the avascular bleb and advance the healthy conjunctiva, or it might require a scleral patch graft with a conjunctival cover. So even during very late, you can get into hypotony. The best or the most important method is to prevent it, and you follow the Moorfield safe surgical system, especially when you are using mitomycin. Make sure that it doesn't touch the conjunctival edge, more posterior and more diffuse placement. That is how you can prevent the conjunctival whitening and conjunctival melts. And thorough washout also. And to prevent hypotony, use releasable sutures and tight sutures. So that is the most important step, so that later on you can release the sutures and titrate it. So use tighter sutures, gentle tissue handling, and wise use of mitomycin, and definitely increase frequency of the early post-op visit. You can manage the flat AC or hypotony. So to summarize, if you have a flat AC and Seedl's positive, it is due to a bleb leak, and if it is Seedl's negative, it is due to a overfiltering bleb. You have a large filtering bleb, and then if it is deep, it's either hypertonic maculopathy. And the first 6 weeks is the most crucial period where you manage the, you do the right procedure, right time, and you can save the bleb and save the eye. Thank you.
Thank you, ma'am, for that excellent talks with the images and all. So we have few minutes to take few questions from the audience.
I have a question, and I would like your expertise, sir. This was about ocular hypertension. What if we get a patient who has come for a routine follow-up, not follow-up, a routine examination, say for change of glasses, and we find an intraocular pressure of say 24 or 25. We do a complete glaucoma examination and history taking. Everything seems normal with open angles, and we label the person as ocular hypertensive. Do you go by all the tenets of ocular hypertension treatment study when the intraocular pressure is 24 or 25, or maybe even if you do the diurnal facing and find that the pressure is in the same range, how do you manage such a patient?
I think the answer is pretty simple in this actually. Whether the patient comes for the first time checkup or the follow-up checkup doesn't matter. No, that's what I'm saying. Whether it is first time or follow-up, the patient has an IOP proven by appellation tonometry.
Yes, sir.
And then by your diurnals, whatever it is, ocular hypertension is ocular hypertension. You just go as per the table, whatever is to be done, like low CCTs, family history, and other things. Like I think she has beautifully explained about that. So you don't have to really bother about whether the patient has come for a review or first time. Once you diagnose ocular hypertension, it is the same. You just follow the pattern of how we need to treat. So 24, whether you want to treat or not, is depending upon the other factors.
Which other factors would you consider?
CCT,
Those
other risk factors.
Yeah.
Usually for 24 we don't treat.
We usually do not treat.
Yeah, that's as simple as that. Yeah,
So,
it's
but what
basic. Yeah.
So what if that 24 is slightly higher, say 28 or 26? Should we treat then?
See, I think again the answer is going to be the same. It all depends upon your risk factors like CCT low, CCT, you have a family history of glaucoma, and you have a 28 or 30, whichever eye has, you go with that scoring, reasonable scoring system, then you treat. But if you don't have a risk factors like a low CCT or family history or other hemorrhage or progression you have not seen, you don't have to really.
Progression, sir, we'll have to wait for
Yeah,
some
that is the
time.
first visit you have
Yeah.
seen. But
No,
if
this
you
is not-
feel,
yeah.
if you really feel you don't, this is a very difficult situation where you are confused. If you don't want to treat, if you can really do a close follow-up, and then if you have the family history of same kind of a glaucoma, ocular hypertension, you will have a better idea whether that patient has shown any progression. So in this same way, you can also see the progression. You can ask them to come for little close follow-ups and then see whether there is a progression or not. If there is no progression, you don't have to really worry. Even if you treat the ocular hypertensives, some still progresses, many they don't progress. But what we are looking at is only a early primary open angle glaucoma, whether they are going to set in or not. So it is reasonable time you can take to understand whether they have a progression. If you really feel okay, I don't want to treat, they can come back for a proper follow-up, then you can still do a visual fields and OCT and see how much is the change happening. In fact, if you have an ERG, you can even see how much is the stress that the RGCs are having. If you have the diagnosis or diapsis or a diagnosis, you can use the ERG and look at the ganglion cell, how much is the stress the ganglion cell is having. So you can even reverse the disease in this case because the cells are under stress only now. If you feel the cells are under stress, you can treat. If you feel the ERG is completely normal, you don't have to really treat. I'm talking about whether you still having a lot of confusion, like say VVIP status. Somebody has said that, somebody has said this, and you really want to do
That is
something.
the question, actually.
You can definitely do an ERG. That really helps. Because ERG is much beyond our OCT and the visual fields. Visual fields is basic. Then comes your OCT proper reading as per your all that,
Yeah.
eliminating everything. And then the next level comes your ERG. So ERG really helps. So that's how I do, because I do have the ERG, I do see the ERG. So that really helps whether the cells are under stress or not. See, the basic idea for all these topics today is back to basics. So if you don't know the basics and you keep treating by looking at the cup, in spite of all this, we keep teaching every year. I think it is the mentor's problem, it is not the mentee's problem. Mentor is mentally still not suitable to teach. So only when the mentors are good enough, I think we will be able to do a better job. I think all of us as a senior faculties here have a role to play majorly. When we are teaching the Humphreys fields or octopus, whatever the visual fields or OCT, we teach the damages. We don't teach how to do the OCT properly first. If we can allow all our students to go do the investigations by themselves and read the manual first, then things will become better than what we are currently doing our practice. So I think you want to.
So thank you, sir, for the clearing the doubts. So I invite Dr. Satyan to receive a memento on the behalf of our KSOs.
It is not mine, actually. Somebody else's is there. So I think they gave me one yesterday. I kept it somewhere. I kept that somewhere.